The following is a conversation. It has the features of any conversation, such as imperfectly expressed thoughts, ill-considered opinions, and the notions of several sleep-deprived brains. Try not to get your stethoscope in a twist about it.
Today we're talking about some of 2024's trends and topics in healthcare and medical education with our guest, Medscape's Jon McKenna. But first, I don't know if you noticed this week, Dr. Oz has been tapped to lead the Center for Medicare Services by President-elect Donald Trump. He'd be working under vaccine skeptic and bear dumper Robert F. Kennedy Jr., who hopes to be confirmed as the Secretary of Health and Human Services. I just wanted to get that out there for people who aren't paying attention, because I think there might be many people who aren't paying attention, but who may.
I would love to be paying attention so much less. I simply cannot not be paying attention, unfortunately. However, I would love to be in the world of not having known that information. This would be so much better if this was a shock to me right now.
I did go a whole 2 weeks avoiding the news.
Did you feel happier?
I did, but then I have stumbled back into my old news junkie ways.
A newsie, you might say.
Yeah.
I've definitely I fell into like the trance of not following the news because I felt like I needed some time to grieve.
Yeah.
And as soon as a few days ago, I got back into like re-listening to my podcasts, and I've come to the conclusion that I have to pay attention to what's happening. As much as I want to hide in my room and not pay attention, I can't do that.
We needed a break.
Yeah.
Now we're back.
Meandering in the margins of medicine, it's the Shortcoat Podcast.
Weird news,
fresh views,
helpful clues, and interviews.
By students, for students.
Subscribe to our weekly show at theshortcoat.com.
Welcome back to the Shortcoat Podcast, the show that gives you an inside look at medical school from the students drinking from that fire hose. It's a production of the University of Iowa Carver College of Medicine. I'm Dave Etler. With me today in the SCP studio, we've got MD PhD student Riley Behan Bush.
Hello, everyone.
M3 Elvira Nguepnang is here.
Hello.
M4 Katie Higham Kessler.
Howdy.
And M3 Olivia Jenks.
Hey.
But if you thought that was all, that's confirmation bias. Is that confirmation bias? I don't know. Because today I'm delighted to welcome our guest, Jon McKenna, Senior Editor of Reports at Medscape, the leading online global destination for physicians and healthcare professionals worldwide. Welcome to the Shortcoat, Jon.
Thank you. How is everybody?
We're hanging in there. The horrors persist, and so do I.
It's funny talking about politics, and I've actually found a way to train my brain to, whenever a political topic comes up, just figuratively in my head, put my hands on my ears, go la 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 la.
Yeah.
And it's working. My sanity just seems to have taken a turn upward the last couple of weeks. It ain't easy staying sane in this country these days.
Yeah, no. I want to remind you, Shortcoats, that we're always excited to offer advice about medical school from getting into graduating and to take suggestions about other topics we can bring you. So what do you want to hear? Go to theshortcoat.com/tell us to make the show your show, because sometimes I run out of ideas and I could use the help. Always. So we're here today, as I said, to talk about some of the trends and topics that you've covered, Jon, on Medscape for 2024. I did suggest some pieces of yours for my co-host to look at from the past year, and I'm sure we'll get to those. There's always so much going on in medicine and medical education, but from your perspective, Jon, what is the most interesting or surprising thing that you've reported on recently?
Ooh, wow. That's a good one. I would say it's most surprising. One of the realities of doing this for a few years, you get surprised less and less.
Sure. Yeah.
I know we're going to probably talk about AI at some point, but in terms of surprising, we have a new report coming out next month. We talked to the physician world about AI last year, and everybody was still really in wait and see mode and really in explain it to me mode. And we wanted to go out and talk to some early adapters. And we did that on the part. We got away from the folks who were just saying, please teach me more, tell me more, and talk to some docs and some medical CEOs in place that are actually putting it to work. And I was surprised at how far down the road they are. I was expecting it to still be in a crouch about AI, but you're starting to see a lot more toe dipping into AI. So that's something that's really surprised me in my last few weeks.
You expected people to be
about that tomorrow, and they'll give you something different.
Yeah. So you expected people to be a little bit more conservative about it.
Not so much conservative as inexperienced.
Okay.
And there's more experience out there among the practicing physicians and the IT people and the medical establishment in general with AI in the course of a year than I was expecting.
What are some of the
It's
main
a conservative profession? So you're right. I was expecting a little more crouch.
What are some of those main AI uses that you're actually seeing? What are the kind of first adopters using? Is it large language models? Is it diagnostic tools? Is it tools to help them write notes? Kind of what are the buckets of AI that are being earliest adopted?
More the latter.
Okay.
You're starting the adaptations tend to be in the what I'll call the note-taking mode, the taking of recording of patient conversations and transcribing it into notes, the turning out of routine patient communication, because those are the applications that are actually out there in the marketplace. Yeah, I mean, at the moment, the higher and the higher value stuff that gets into the quality of patient care really isn't out there in the marketplace yet. So it's still in the discussion stage. But you talk to docs, you talk to others who are actually working out there in the medical world, and they'd all love to put those transcription applications to work and get away from the EHRs for a while, and that's happening.
Yeah, anybody who's listened for a while understands that one of my pet interests is how people are using AI, how I can use these large language models. And one of the things I realized early on was that it seemed to me anyway, the best use of AI would be in those sort of
it's the saving
patient encounters,
time.
the saving time
Yeah.
stuff, not the diagnostic stuff. Not only because that might be harder, but also because I don't think that's where the need really is.
Perceived need.
Perceived need. Yeah, absolutely.
Yeah, and I don't know if I go down the perceived need just yet. I mean, it's the hardest challenge to surmount. So it's going to take a while. And it's also the one where you've got the most suspicion at this stage of AI generation, especially among the physicians. But, the ambient AI technologies definitely knock out that low-hanging fruit and start to free up some time, for physicians to actually have quality experiences with their patients.
Yeah, because I was reading that people spend about twice as much time on the administrative tasks of a patient visit rather than on the visit itself and the other things that go along with that, the diagnosing, the testing, all that kind of interpreting tests and things like that. So,
and then we have to assume in a best case scenario that the system will see us spending more time with patient, less time with admin, and not just say, you can see more patients. And so that's always the I'm waiting for that other shoe to drop, which is in the best case scenario of AI world is we get more time with patients, more time for connection, more time for more time to build empathy, more time for all the good things that you want out of an interpersonal relationship. But I'm cautiously optimistic that the system will stay as it is currently on track to do.
I guess that'll be up to you guys maybe to...
Will it?
Well, I would say it will be up to you guys to push back and to monitor and to push back and say, no, that's not why this is a good thing. It's not to get more done. It's not to get more RVUs in your pockets.
But they're not wrong to be at least a tad suspicious because, I look very assiduously in the comments section of our surveys. There's a lot of cynicism out there about that. A lot of docs are convinced that, hey, as soon as the stats and the metrics show that you're spending less time on administrative tasks, the idea being, hey, how many more patients can you shoehorn in?
Yeah.
But I think too, like right now, a lot of those administrative tasks are being done at home in hours that are not officially accounted for, so in order to, the patients are already shoehorned in and the extra work is spilling over into home time in a lot of cases, at least. And so in order to shoehorn more patients in, you'd actually have to literally extend the clinic hours, and then it would be official. And then you'd have to acknowledge the hours that are being worked.
Right.
Like it would be on the books, perhaps.
I like that counter. That makes me.
I hope.
Plus, it's really hard to justify something shorter than a 15-minute appointment.
Yeah. How would you
like 15 minutes already isn't enough.
Yeah. I had a whole 25 minutes the other day.
Oh, wow.
I was like,
wow, living the dream.
I know.
Are you a complex patient, Dave?
I'm very complex. Okay. Aside from that, let's start with one of your reports this fall that's pretty important to us, I think, is the medical school experience report from about a month ago. There's a lot in it that I hear all the time from my co-hosts, things like talking about, debt, long hours, imposter syndrome. Give us some of the highlights from that report.
Well, from the big picture, I was really impressed. First of all, this year, we used to address the whole aspect of what your quality of life and your lifestyle is like during med school, wrapped up in what's it like in your classes and the level of clinical instruction and that sort of thing at one time. And you realized, okay, really talking about two different topics there, two different challenges and that deserve individual attention. So we broke them out this year. But I was struck by the professionalism, I'll call it, of the med students that we were surveying out there in terms of, you talk about med student experience. Do you think it's kind of open season to complain?
Yeah.
But they're able, the majority are able to really objectively evaluate their med school experience while still complaining about the stuff that people have always complained about. So the study hours, et cetera. There were some really measured, objective, and positive evaluations of the faculty and the amount of time you're getting and the on-point aspect of classes that they were talking about in our survey, while still, talking about some of the grind issues.
There's a particular talent to complaining professionally that students learn.
It's a core competency.
It is the
wow.
ACGME will.
Somebody needs to teach me that. I get into trouble too much, but we'll learn here.
No, I mean it's you've got to talk about these things in the right way, or else nobody's gonna listen to you. And I think you guys learned that pretty early in the M1 year, if you haven't already, right?
I don't think it's explicitly taught.
No. This is definitely a hidden curriculum.
It's a hidden curriculum thing. Yeah.
There's also the hidden curriculum of just being in the Midwest, which I don't know how many of you came from elsewhere. You're from the East Coast.
I'm from the East Coast.
Boy, yeah. If you're from the East Coast, somebody asks you how you are. It's like a bonding experience to complain about something. Yeah. If you do that here, you get this like stricken look, like you've really committed a social faux pas.
It's so interesting because having grown up in the Midwest, like it's like all the basis of all of my friendships ever.
Is complaining?
Like straight up complaining.
Oh.
Like, so I don't know. Maybe
I need to find the right audience.
No, you complain to your friends.
Yeah, maybe that's it. Is like there's a wall, and once you cross that wall,
yeah.
Then...
I like it when I walk down the hall and somebody asks me like, "How you doing?" And I suddenly my brain short circuits because I know that what they really want is something light.
Never better.
Yeah. And what they ultimately get is something a little more complicated than that. Again, I'm complicated.
There's another topic I wanted to throw out there. You were asking about what stood out to me. It was really startling how many of the med students brought up imposter syndrome, either in the comments. We give an opportunity to kind of unload in the comments section. And we also asked about it specifically. And, 6 in 10 of them said they feel that at least sometimes. And we're getting, both in the interviewing, the comments, getting all this commentary about imposter syndrome, so much so that we're going to do some specific research on that in 2025. But it left me wondering, you're talking about extreme high achievers here. And I'm wondering, okay, do you come into med school with those kinds of misgivings, or is it taught? Are you picking it up from your school and friend groups? But it was startling to me.
I think one way to motivate excellence is to always feel like you're not enough. And it's not a great long-term strategy, but it is what motors a lot of us through much of our education.
Yeah, here's a secret. I think it's what pushes along a lot of your deans and faculty and residents, and all the way through. I would be curious to hear more about imposter syndrome among that group of folks, because I think it's reasonable for you guys to feel sometimes like imposter. You're being asked to play doctor a lot of time. Like whether you're talking about like your interactions with standardized patients, your OSCEs, things like that. Like, you're supposed to play the role. Generally speaking, you're supposed to play the role of something that you aren't yet, right?
Yes.
Yeah, but kids do that when they're playing house and stuff, and they don't feel like they're imposters.
Yes. Can you imagine? Am I a good enough fake parent?
I feel
Never
like some
gonna
of
make
it.
architect.
Yeah, I feel like some of it too is this like lack of agency that people maybe feel when they're going through medical school. Because one thing that I think about a lot, having been in school now for lots of years, so like doing the extra long track, is that you get into this world and you are an adult for all, like in all sake of the word. You should be in a career. And so you feel like you're in a career. School feels like you're in a career here in medical school. Yet you have no agency to change schools, to think about making money, to do anything other than stay on the path. And I think that's a really interesting part of what we go through, is that like lack of agency to like really even like make a change if you wanted to. I talked to a lot of my friends who are, just working in lots of different areas. They could work for different companies. They could switch jobs. They can do anything. And it's not that we would want to switch jobs, but there's this feeling of like stuckness that I think can like build that feeling of like, I am here, I am doing it, and like I can't really do anything about it.
Yeah, because let's face it, I think a lot of schools don't even take transfer students because they've got their curriculums set the way. It's not like undergrad,
Yeah. And then you throw that along with, you've come from a larger cohort of some high achievers, some low achievers, to now a bundle of high achievers. And now the comparison is different. And comparison is the thief of joy, or whatever people say. And I think all of those factors compound onto what we would call imposter syndrome.
Right. And going back to Jon's question earlier about potential reasons that could be creating imposter syndrome, I think you described a few of those reasons. I think for me personally, I did not grow up with a physician in the family. So coming into medical school, I had, I would say, a lot more imposter syndromes than my classmates who had family members, especially parents who were physicians. And so I've had to develop the confidence in myself to believe that even though I didn't have that in my family, I can become that. And I've gathered that confidence from a variety of different sources. And so I would highly encourage medical students out there and pre-meds to find different sources from which they can gain that confidence, because we are going into a field that is so taxing on the mind, on the body, on the soul, and having a variety of different sources from which we can maintain a sense of who we are can help us to go in every day and do our best.
Yeah, your point is so important about building confidence kind of internally, because I think from my perspective of having done some in medical school and then having gone to the PhD, in which you're just kind of like thrown into the ether and then they just like say, figure it out. What I found was that when you're in medical school, you're getting told how you're doing at all times. There's so much external feedback as to what you're doing. Grades, feedback on clinicals, feedback more than you would ever want it as far as how you're doing, who you are, how much confidence you have. And I think a lot of students put a lot of weight into that.
Yeah, it's weird how often you get evaluated on aspects of your personality.
So much evaluation. And then I went to the PhD and I got none. I got like a meeting once a week with my boss and he's like, yep, you're on track. And I was like, wait, but like, aren't you going to tell me other things? And so I think that was such an interesting experience for me to go through. And what I realized, and to your point, was like, you have to find that confidence almost like outside of the external validation of what you're getting from school feedback.
Right.
It's hard to like kind of do the la, ignore it.
And it's not, I can't help but think that the system of being constantly evaluated doesn't just end in medical school. It continues beyond medical school. And so if we first as people, and then secondly as physicians, don't have, like you said, like something outside of this sphere to validate us, to strengthen us, then at least for me personally, it's going to be very difficult to show up every day and be my best, which my patients require that.
Did you do anything in particular?
Did I do anything in particular? I did a lot of things. I would say first and foremost, I'm a Christian. And so I pray a lot. I read the Bible a lot. I also surround myself with people who also believe in God. And so they remind me of who I am.
Sure.
For example, during my surgery and OB-GYN rotations, I had some days where I just felt like, yep, I quit.
Yeah.
I want to go home.
Yeah.
And so I texted my mom is in this Bible study group, and I texted the ladies in the group, and I just told them that I really need some encouragement because today is extremely tough, and I don't know how I'm going to even put one foot in front of the other. And one lady after the other just typed a Bible verse, and I just read those Bible verses all day, and the day after that, and the day after that. And so that's where I draw that's my main source of strength.
How amazing. We all need a group of people to text and send us encouragement and things like that.
Yeah, they're wonderful.
That's very cool.
I can bring sort of an opinion from someone who isn't Christian and who doesn't have a strong faith base. I also sort of needed some of those external like validators for the days where, you're just doing everything not quite right and can't quite seem to fit in with the team and things aren't going well. I started writing down things that people had said to me that I'd done well.
Ooh,
and so
I
keep like a journal of just like quotes from attendings and residents and friends. It's like a list of things good. I can look.
Because we have a negativity bias. And
Exactly.
Yeah. And so I keep, some of it's handwritten, but some of it's on my phone. So if I need to like just go and scroll through it, I can like just go and see like what other people have said.
Yeah,
in the
me
really good.
Personally, I get nothing but positive feedback all the time.
on the internet.
So I don't
Dave has a
Internet's
positivity
only
bias.
positive.
I have a positivity bias. I don't need any of that.
We all want to be like you.
Well, you can't.
But so things I'm hearing, which sort of resonate with my experience too, is that you need an identity outside of medical student,
right?
And you need a support system. And so then your survey comes along and says, actually, it's really hard to maintain those things in medical school.
I do not like being the bearer of bad news, believe it or not.
There were other things in that survey. What did your survey find out about students' experiences with mentorship?
Well, probably a failing of the survey, but we did not drill into specifically into mentorship.
But there were some questions about how satisfied are you with like your relationship with faculty and things along those lines, right?
True.
That sort of get at that.
Yes. The generally very solid in terms of happiness with the quality of faculty. Generally happiness with the curriculum, general happiness, high satisfaction levels with the faculty, although that's not specifically on mentorship. We drilled down a little bit there into health and equity topics, and because I know that's a really important level of curriculum and high value for a lot of students, and they supported us on that. Like the schools were doing a solid job with that,
and that they're seem to be doing better, as far as I could tell from the report. Like things seem to be moving in a positive direction there. Maybe we're not where we need to be at as far as equity goes, but.
85% of the students said it's very or somewhat important. So, not much needs to discuss there in terms of whether it's a high priority topic. And 72% of them said it's at least sufficient. And in the context of the way we ask questions, that's actually a fairly high and praiseworthy level. And as you point out, the med schools have been responding to this. You guys could talk about that at a granular level, but it's clear in some of the interviewing we did that the schools are responding with coursework in this regard. So there's some analytical tools and ways of looking at equity that are being taught.
How do you guys feel about the level of instruction you get in those areas, or the experiences that you get in sort of the equity area?
Anecdotally, I know I've had a lot of attendings and clerkship directors be like, who went to the University of Iowa or like other local and relatively local institutions who were like, I didn't get this.
Right.
I'm really glad that we're teaching this and that I get to teach you about this because I didn't get this. And so like, not only does it teach us, but it also forces, the attendings and the people who are teaching us to develop a knowledge base that I think is, one of the most crucial aspects of medicine.
I do think that our school is doing a great job of informing medical students about topics of diversity and equity within medicine. Specifically at the end, and sometimes during our clerkships, we are assigned articles to read about how that particular specialty is engaging in equity efforts. I remember during my orthopedics rotation, we had a few articles that we had to read. And at the end of the 2-week rotation, we sat down with, I believe, one of the clerkship directors, and we discussed a few of those articles. And I think I really benefited because I was able to see, and also during my radiology selective, this happened as well. I think I really benefited because I was able to see what efforts radiologists, specifically during my radiology rotation, and orthopedic physicians were doing specifically during my orthopedic rotation. So it's been really fascinating to see what physicians are doing within each sphere of medicine.
Cool. Well, I like to hear that, especially ortho. Ortho bros, they have a reputation.
Right. I wish I remembered exactly what we discussed, because the last time I was on that rotation was about 1.5 years ago. And it was extremely interesting, but I've forgotten it all now.
It's all right. It's in there somewhere. It's doing something in there.
They were doing some really great work.
Was it something about how likely people were to take a recommendation for a knee replacement or something like that?
I believe one of the articles included that. Yeah.
Well, there's all kinds of stuff. There's like, pain management is a big area where, equity is a problem. What else? Just access to care, I think, a lot of times is a big issue. So,
and an issue in equity that I think gets overlooked still, it's not the first one we think of, is the pediatrics. Often, there are lots of emergency departments that don't have competent people to evaluate pediatric complaints. They don't have the right equipment to treat pediatric patients. And there's been some stuff coming up. So, yeah.
Okay. Yeah, kids.
I
spend more time in the emergency room with my children than I do with myself.
I know, you would think. But they reimburse at lower rates and they don't vote. So,
Yeah. Well, okay. Yeah. Get out there and vote, children. What's wrong with you?
I know, it's all their fault.
Medicine is politics, children.
Take your 6-year-old to the polls.
I mean, really. Anything else you want to say about medical school or ask about the medical school experience?
I was just curious if in your research I don't think the overall sample size is necessarily large enough to make this a part of what you're publishing online, but is there any trend that you are seeing or any hint of a trend in terms of different regional variation with how students are perceiving their medical school experience? It just has to be so different at different places. And I'm kind of curious about that. If there's anything that maybe it's too much to ask, but that you could tease out.
I don't think it's too much to ask, but nothing jumped out, in terms of regional trends there. Sorry.
I guess you might imagine that because schools are all accredited by the same group, they all have to do something to meet those accreditation. They can do those things in a variety of ways, though.
Right.
So you could imagine that.
Well, and culture is sort of affecting the overall, some of those responses too.
Yeah, the LCME doesn't tell you how to do something. They tell you what to do, and then you have to figure it out and then demonstrate that.
What I think is interesting just in the medical school variation is that so much of how you might enjoy medical school is actually more so about like the residents and faculty you end up getting, which is not actually determined by the like medical school at large. Like I think this about rotations and how a rotation could be genuinely defined by the residents you get in that given year, in that given time, even in that given week. And you could hate or love a specialty because of the people you work with. Yeah. And so that's so interesting. Like, I just think that's such an interesting fact that you could never capture on a survey, but you couldn't even capture in differences in curriculum because curriculum won't define the types of people you're going to get in that given week on that given rotation.
Right.
One topic I wanted to throw out that's come up in our surveys on med students and residents, the work-life balance kind of stats. I mean, sorry, they do just suck. I mean, amount of social time, ability to, sorry, believe it or not, nobody's exactly knocking them dead on having quality friend time and dating time and basically looking after your most fundamental needs. But the med students, though, seem to be doing better on getting enough sleep and on getting enough exercise, more so than over the last couple of years. And, it's easy to sound trite when you talk about that. And they're saying, they said their med schools are actually giving them more than lip service on making sure that they have that ability. But, to me, that's encouraging. And I kind of read into it that's just you all, the med students, are getting a lot smarter about carving out that kind of time for working out and getting real sleep time. Love to hear your thoughts on that. Is it just you guys being smarter?
I know we were joking about this before the show, but I do think in the preclinical curriculum, some of it is that we can get some other things done if we have lectures on Zoom or recorded or something like that. The fact is that there are times when our brains are just not going to be engaged enough to engage with a lecture fully. And if we can do the dishes and listen, or, sit down and have like some time to relax on the couch instead of sitting up with a bunch of people socially, that sometimes fulfilling...
Don't like that social thing.
Sometimes just fulfilling some of those tasks is helpful. And I wonder if, COVID did have some impacts on our ability to learn and adapt to that environment.
And if it's you're saving an hour of commute time, half an hour each way, potentially, that's an hour of sleep.
Right. And I've definitely walked into the women's locker room downstairs and I've seen some of my classmates get on the treadmill and be on the treadmill and also be doing flashcards at the same time.
Wait, we have a treadmill?
Yes.
In the women's locker room. Do we have a locker room? Okay.
Yeah.
Continue.
Write that down as something that we need to tell more people about.
Yeah. And I myself I love to work out. So I am always, well, I wouldn't say always, but when I typically work out, I like to work out with like my phone in my hand. So I'm doing flashcards, or if I'm able to set up my laptop in front of me, I will set up the laptop in front of me and watch a lecture while I just walk. And so that's how I've been able to like squeeze in some workouts.
Yeah.
I think this is just a symptom of kind of a larger societal shift, in that I think there's a lot more young people, kind of the Gen Z millennial-esque region of people that are interested in wellness and what that looks like for themselves. I think we see this in, Gen Z drinking less alcohol and having more time for friends and taking more of an emphasis on taking time out of your day for sleep and exercise. And I think to some degree it can go too far, but I think that has basically kind of why are medical students doing more? I think it stems from just making it a bigger priority, partially because schools are telling you to make it a bigger priority, and partially just because society at large says these are awesome things and it's cool to care about yourself. And I think that's a really neat aspect. I'd be really interested to see if the medical student prioritization of wellness actually trickles into resident care of wellness, if it actually will be the same populations that cared in medical school that ultimately cause greater wellness adaptations in residency. So better sleep, better exercise because the habits were formed at the time where they could actually form them.
I wonder the extent to which those habits can persist in an environment that is not conducive to the maintenance of those habits.
Say residents.
What I'm specifically thinking about is, for example, a more competitive residency versus a less competitive one, and how either might affect the ability of a student or, a resident to maintain the habits that they've developed all throughout medical school. It's a question that I think about every once in a while.
We're going to get to the resident side of it. But there's one more thing I wanted to say about carving out time for just healthy habits in medical school, which was that the way that you learn, the methods that you employ to study probably has a lot to do with the amount of time that you have. So if you're spending a lot of time studying inefficiently, then you're not going to have as much time to do the other things in your life. And so that's a learning process as you get into medical school. The things that you did before med school to learn, like reading, highlighting, like traditional studying concepts, don't really apply as well in medical school because there's just not enough time to do it in that way. So you adapt, you figure out new ways of doing that so that you do have that you're more efficient, you do have time.
But I think constraints can help with that process as well. Like if you make it for sure that I'm going to get 7 hours of sleep every night. I mean, my constraint was having kids, right? That like after dinner, I'm not going to study because I got other things that I'm expected to do. And so like it just really compressed and I had to be super efficient. I did not waste any time when I was studying. I don't know that I had like the whole system figured out completely, but you can put sort of those hard boundaries on certain things that, and we also had faculty telling us along, in different classes, like in our neuroscience, about the importance of sleep. Like, so it's coming up like medically, this is how your brain works. You're not going to learn if you don't sleep. You will learn better if you get aerobic exercise. Like these are facts about, so you can't like avoid that and do your best as a medical student.
And we as medical students are counseled on the importance of a support system. And over the years, I've definitely relied on my support system, and I have outsourced certain things in my life that I was doing very well before medical school.
Like what?
Like cooking.
Yes.
Yeah.
Actually, that one I'm still learning how to do. But
it's all right.
Other things.
Are you consuming calories in a way that allows you to exist?
Yes.
Then there you go.
I am.
Instacart is amazing also.
Exactly.
Not a sponsor, but
Shout out to my mom.
Give us a call.
Apologies to my upstairs, downstairs, and next door neighbors for my 30 seconds of blending at 4 a.m.
So let's move on to the residency programs. They are making some progress in lifestyle and happiness of residents. Looks like fewer of them rely on things like wellness modules or mindfulness meditations as go-to solutions. Instead, looking at more systemic changes. Is that what you found in your research?
Yeah, there are certainly a tendency to rely on healthier habits. Is a trend we've been seeing over the last 3 years. In other ways, the stats were just really discouraging. I mean, 1 in 3 of them say they rarely or never have time to look after their own health and wellness. 2 out of 3 of them said they have enough. They feel like they have some time for a social life, but that's on the downtrend. 37% of them said that the work-life balance coming in or was worse than they expected coming in. Yeah, I just don't know how you sustain that kind of, baked in sort of grind, even against your own personal habits. I mean, I guess what I'm saying is at the end of the day, our research just really indicates what a gauntlet residency is. And I know I'm not surprising anybody in your room there, but it's tough.
Well, I did note that some of the people that you collected quotes from were talking about the kinds of counseling services that are available in residency. I don't know, I couldn't tell if they were embedded counseling services like we have at med school, and which I think has become more common to have at med schools, although it's not universal. We definitely have a counseling service here that students utilize.
It's interesting you talk about that. There was one med student I talked to who said, yeah, we don't have institutional resistance to reaching out for available counseling services, but the reality of the situation is if I don't see you in the halls ever, or if I don't see you around the quad ever, if I got to drive across town to get somebody in a participating plan to give me counseling services, I'm probably not going to do it. There's not going to be a trust level. The time in going to it is just going to make my life harder, and I'll probably just suck it up. So if I can reach out and touch the counseling services on a periodic basis, fine.
Yeah, that's why I'm like, I feel like at least in large hospitals, I mean, it should be everywhere, but at least in large hospitals, it shouldn't be that much of an issue to embed a counselor or two in your program so that you can respond so that you're visible, like you say. I think that's the big benefit of having our counseling service sort of embedded within student affairs, adjacent to curriculum. I think that it feels important to me.
It feels like the only real thing that residencies could do to improve resident wellness is actually just like give back time.
Right.
And it feels like the only true, just kind of marker of wellness is like how much time do you have? Not only to just like rot and do nothing, but to also take care of yourself. Like I think those are both necessary things.
Let's not call it rotting. Let's call
Sorry, I like the term rotting, but I agree.
I like to call it fermenting.
Fermenting. Okay, sorry. That's also good. Fermenting is just a fancy rot.
I agree. You're allowing yourself to
transform.
Okay, I like that.
To become one with nature.
Yes. Okay, so we are fermenting. Regardless, I'm going to be doing so much fermenting this weekend. But I think that ultimately no wellness is given, no extra sleep, no extra time to take care of yourself, no extra time to cook. Nothing is good without extra time. Yeah. And unfortunately, I think the residency programs can do all they want to benefit wellness kind of while they're there. But until there is simply more time to take care of ourselves and less burnout, like I don't know, maybe
and there's this, I don't know, like obviously there is a level of time that needs to go into training, but there's also been talk without much happening about like competency-based training, because really at the end of the day, what we want is competent doctors, not doctors who have spent X number of hours at the hospital.
Who trained to shit.
Right. And there was all this like hand-wringing when they reduced the work hours to a cap of 80 a week that, doctors are not going to be prepared. But I think it was your results actually that showed that in part that didn't happen, that didn't come to fruition.
I was thinking, as you were saying that, I mean, one of the things you see very sharply in our data, in our list, is a difference in attitudes about this from people who are farther along in their careers or approaching retirement than younger docs or people who are just coming in. And again, this is something that's not going to shock anybody here, but the people who've been there for a while feel like the residents should suffer just as much as they did. And do the same grind that they did, and how dare you suggest that you have it better?
Do we have a word for this phenomenon yet? Because I feel like this is
Germans must.
I mean, like, what is this term for like, I suffered, therefore you must also? Do we have one?
Is old fart syndrome?
Like, I don't know, but it's everywhere. It's crazy. It
I
just
feel like
never
there
goes
should
away.
be one. I feel like there is one. I just can't think of it right now. But I feel like I've come across it.
It permeates everything.
I'm gonna go later. I'll go to Google Translate and come up with a German
portmanteau,
that like Schadenfreude or whatever, and we'll make it a thing.
I have never known what Schadenfreude means.
The joy that you feel when other people are suffering.
So with your surgical attending, is the primary emotion.
Or when something goes wrong for somebody else.
I'm curious from everyone's perspective, how much do we feel like residents feel like they have say over what is happening within their programs? I know none of us are residents right now, but
what aspect do you mean?
I guess, do the residents feel like if they band together, they could make changes, or do they only feel like they could make changes once they are attendings and then they can go top down? Do they feel like they can make changes while they're even in it?
I think it very much depends on the program, like program by program within an institution.
Yeah, I mean, and I agree. Kind of change.
Yeah.
And what kinds of change?
There have been unionization attempts, for instance, and I don't know how.
UCSF and maybe some of the other UCs are unionized.
Yeah, it might be
harder if things get bad enough.
Right. Well, it might be harder in like a community hospital situation to do such things because there are just fewer people. But I don't know.
I do have another question, Jon. Regarding the wellness data in residency, were there differences in wellness maintenance across the different specialties?
The answer to that is I'm sure they're there. We did not explore them in our latest reporting any farther than, the specialties with longer residency requirements tend to have the higher levels of burnout and the more difficulties in health wellness. So I apologize. I can't give you more drill down than that.
Oh, that's all right. Thank you.
How do residents' personal relationships fare during residency, according to your information?
Not great. Not great.
This uplifting episode of the Short Code Podcast is brought to you by...
I hate getting into that. It can be so sad to talk about, but they're struggling. I mean, they're struggling with time for family, friends, for social life, for dating, all the things that help you relax. It's tough in residency. It's worse than it is in med school. And that's just the bottom line. That hasn't changed in the last few years of our surveying and our reporting. I'm not looking for any material changes over the next couple of years when we ask about it, unless you start to see some of these structural changes being experimented that you guys are talking about.
I mean, it goes to Dave's point. Medical school, you get more time because you study more efficiently. There's like no way to make residency more efficient other than like live closer, be faster at notes. It's all trying to capture your own time back, which in medical school you can because you can do flashcards on the treadmill. You have some agency over like how you're doing it. But unfortunately, there's no real way.
I do plan on outsourcing some other things in my life when I get to residency,
which I think is really important to talk about. And
I think I mean a certain portion of your lowly salary as a resident should definitely go towards cleaning service, as you said, food preparation by other people that aren't you.
It was crazy eye-opening the day that a resident looked me in the eye and is like, "These are the things you should think about paying for in order to buy back some of your time." And I was like, oh my gosh, it's almost as though they said this like unsaid thing to me. And again, maybe that shouldn't have been that profound, but coming from this hardworking mentality, if I work hard, I can achieve it all.
Yeah.
To recognize like you don't just have to work yourself to the ground and you can actually do this. It felt like a giving me permission to not just to take that value that I have, that I'm a hard worker. I work hard for my home. I work hard for my personal relationships. I work hard for school. And it's okay to just like do a little less of the working hard.
I don't want to
be a little more efficient.
Yeah.
Which I thought was really cool.
Yeah.
And what are you hiring out?
Nothing yet, but that's because I have extra time currently as a PhD student. But I mean, I talk frequently about, the day will come that I would want to do kind of like a cleaning service. I've got a dog. So like finding ways to make it easier for a dog walker, food, meal prep services. If I value kind of the food that I enjoy eating and that fuels me, finding ways to make that easier.
Free things like, Hy-Vee, our local grocery store, you can, order things online and they'll do the shopping for you and you just go and drive up and pick it up.
Yeah.
Right.
And even some like low cost things that for me, I'm like, I love working out. I hate planning on what I'm going to do to work out. Paying for like a $10 a month workout program that's just, I show up and I do, and I don't have to think about it. Those things are invaluable to me. And I think it goes up as you go up. But I think the money becomes part of the problem. And that's where like, if residency programs want to give their residents more of a life, give them some stipend so that they can do these things, that they can pay for these extra things. Because unfortunately, you've got a numbers problem at some point.
This is a question that is born out of reading what is the title of that report? It's the report that discusses the gender pay gap.
The
female physician compensation report.
Yes, that one. And one of the physicians in the report stated that a way that we could combat the pay gap is by removing negotiation from the hiring process. Based off of what you know and based off of the data that you've gathered, is this feasible? And if so, how can we go about incorporating that or removing that from the hiring process?
Ooh, that's a...
Is it feasible? Yeah, I think it's feasible. Is it likely? I think not. Just making a judgment that, we've got a whole economy that rewards chance taking and aggression and holds up as great examples, people who go to bat for themselves, who are willing to stand up in a job negotiation and ask for more and see how much they can get. And, and people tend to be typecast or identified as comers in that situation. So when you're talking about standardizing compensation and benefits and taking those out of the realm of negotiation, I think a lot of administrative offices just aren't going to go for it. So would it be feasible to help equal out some of this gender pay gap that just flummoxes me? And I've never, in the last few years, gotten ever a really good explanation on why this should continue to be baked in. But yeah, that would be feasible to do it. I'm just not optimistic that a lot of medical employers are gonna.
Was that the big reason why the pay gap exists? Because people don't want to negotiate?
I don't think anybody, even somebody who purports to be an expert, can really offer you a succinct list of reasons for this, because there's no good reason for this gap at all. There's a lot of things supposed, in terms of a disproportionate amount of time spent on family and parental support, on differences in negotiating style from the outset, differences in mentoring resources available. And I can see all of those contributing in some way, but not in a substantive way. I mean, there's a gap here that's baked in that I've never talked to anybody in the last few years who can adequately explain.
So I think in other areas, like if you look at the economy as a whole, my understanding is that a lot of the gap can be reduced to sort of a motherhood gap, that men and women start out in their early careers fairly equal, but they separate in the childbearing years. So am I understanding that that's not, it's even worse than that in medicine, that it's like never equal from the get-go, even for when you're comparing single people or childless people?
Certainly that's a way to look at it. I mean, there's a gap that starts as soon as you start independently practicing, and it just keeps getting wider until, late 40s, early 50s. And you can look at it then as, okay, well, maybe you've reached finally the pinnacle of experience and wisdom, and it finally starts to benefit you in the pocketbook. But one of the female physician advocates I talked to said, not so much. I think it's mostly because people are dropping out of the profession or retiring more frequently at that point. So it doesn't have a chance to widen.
Especially flummoxing side by side with some of those studies that, at least in looking at specific outcomes, that female physicians have better outcomes for things like post-surgical complications. And
another interesting thing is that the kind of like perceived, I guess, I want to say like enjoyment of your salary, but maybe that's like the wrong terms for it. But how you perceive whether you're being paid fairly. And what I think is interesting, and maybe there was something in the surveys that made me think about this, but it was how like female physicians will often take on a lot more administrative burden for not more pay. And so I think there's this extra perceived idea of like, I'm not being paid enough because I'm doing all this unpaid work, or I'm doing the job of 3 more people and I'm not getting paid for it. And I think this happens kind of across the board, is that oftentimes these kind of like pseudo leadership roles, the ones that don't come with actual promotion or actual pay, get absorbed primarily by women. And then you're doing extra job with no extra pay. And that goes to then you're not negotiating for yourself. And there's kind of all of this like mumbo jumbo within it. But it leads to also not only is there a true gap, but this like perceived underpaid mentality, I guess. I don't know.
And something else that I found to be strange when I read the report is that female physicians reported not getting as many resources as male physicians, not getting as much support from physician assistants, from nurses. And my question for you, Jon, is would you happen to know why that is the case?
I don't know why. You're right. They do complain of that. And I don't have a great answer for you in terms of is it driven by the nature of the assignment, about where they are in the administrative pecking order in terms of whether they automatically get more resources. I just know that it is something that a lot of them bring up as, underdirected. I mean, there are structural things like the amount of mentoring resources and that are unequally divided among male and female physicians that gets brought up a lot. And I suspect, but can't really prove to you or give you quantitative data on that's one of the outgrowths of that is that, people who have grabbed up some of the primary department roles automatically get greater PA and NP resources.
Jon, another interesting question that is kind of mumbling through my brain. Did you collect any data on whether the women who you talked to or surveyed actually have partners, kind of dual income houses versus single income houses? I also wonder, again, to the kind of perceived gender gap. And again, I agree that the gender gap is very much there and true and to the point of negotiation. I wonder how many women don't negotiate, because it seems like women who are working often will have a partner also working. I don't think it is as common, maybe I'm making a vast overgeneralization, that women would be working and as the primary income earner and the only income earner for two adult household. And so I'd be curious to know if you collected any data on dual income versus single income, but two partners in a home versus kind of single income total.
Right. We've looked at that. It's the marital partnership rates tend to be similar as male physicians. The tendency for your partner to be in healthcare is high and tends to be at a similar rate with men. The divorce rate is similar to men in medicine. So there's not a pronounced gap there. So trying to answer your question more directly, I think they enjoy a two-income household that may or may not make them more likely to accept certain situations about at the same rate as the men do, or as men are, rather.
Do we continue to see the difference in wages in specialties where there are a higher proportion of women? So fields like obstetrics and gynecology or psychiatry, do we still see those differences?
I didn't look at that specifically, and I can't really answer the question. I'm sorry. I mean, I do, we do see them gravitating, toward some of the higher paying specialties in comparative purposes like anesthesiology, OBGYN. It's interesting that, if you ask them how happy you are with your compensation, some of the specialties where they answer that in the affirmative most often are the ones, you would expect, neuro, dermatology, oncology. But you've also got some specialties like public health, psychiatry, pathology that aren't in the pecking order terribly well paid, but they also feel, very happy about their compensation levels. And it underscores to me a trend that you start to see where women or female physicians more often than men are making a broad-based decision about their specialty that goes beyond the dollars. They're looking at specialties when they first get in with a more holistic view about how do I think I'm going to fit in this specialty? Will I be happy in this specialty over the long term? Will I make a difference over the long term? They're making a broader based decision than the typical male physician is. And so, you see higher levels of satisfaction with the pay as a consequence. I think they feel like the trade-offs were expected.
I do think there's sort of a bigger point that like we focus a lot on how do we get women to be paid more. I'm not saying like we need to pay men less. That's not the answer I'm going for, but there is sort of maybe there's something we need to do to help men also consider how they're going to be truly satisfied and happy in life.
Sure.
And if you're miserable, the answer is not more money.
Sure.
Yep. I can tell you that from working in my job. Money is not the secret to happiness, apparently.
However, if you wanted to divert some of the money from medicine to, say, editors, I think that
absolutely.
Worked.
I think
there's an easy pipeline there. I think we could just tap into the medicine to editors pipeline. The big editors are really seeping up the medical money.
Well, that's all I had. Anything else you guys want to bring up before we end this?
No, I think these are really interesting. I think it gives you food for thought as far as is what I'm feeling and where I'm at actually felt by other people. And I think it can really bring people together. So like, is what I'm feeling about medical student or medical school also being felt by others? And even if you're not in the majority, I think it feels really good to recognize that there's like a full spectrum of feelings about medical school and residency. And depending on your positivity or negativity bias, when I look at residency, I see, sure, 37% are not sleeping, but I also see a large percentage that are having time to take care of themselves. And maybe I'm a little too positive, but that gives me some hope. So I recognize we can talk about all the kind of negative parts, but I still feel like excited about what could come.
Put yourself into the groups that you want to be happiest.
Yes.
About with
manifestation.
God, that was
you say
among the worst sentences I've ever said. Well, that's our show. Jon McKenna, thanks for joining us to talk about these topics.
Thanks for letting me drop in. I enjoyed it a lot.
Listeners, go check out Medscape.com. They've got a lot of great information. I go there all the time to get my news about medicine, medical education, the business of medicine, all that kind of stuff. Strong recommend. Riley, Katie, Elvira, Olivia, thanks for being a part of it.
Thanks, Dave.
Thank you. Thank you, Jon. And
what kind of ridicule should I endure if I didn't thank you, Shortcoats, for making us a part of your week? If you're new here and you like what you heard today, follow the show wherever fine podcasts are available. You know where they are. Go to them. Let me know if you don't find it. I'd like to know. The show is made possible by a generous donation by Carver College of Medicine student government and ongoing support from the Writing and Humanities program. Our music is by Dr. Vox and Catmosphere. I'm Dave Etler saying don't let the bastards get you down. Talk to you in 1 week. Hi, Shortcoats. Look, life in medical education, life in America, life in the world is often difficult. And I often wish I could help. All I have is this podcast, but in my wildest dreams, you have the support you need to lead a life of your choosing. You deserve to be happy, healthy, and successful in whatever ways you define those words. So if you need support because you've experienced racism, discrimination, harassment, mental health crises, I want you to be able to get the help that you need. And so I'm going to put some links in the show notes to some resources that you can use. But the bottom line is that for what it's worth, I see you. I know you're out there. I wish I could do more. Maybe I can in ways that I don't understand yet or know about. But I see you, and I'm glad you're here, and other people are too. This Shortcode podcast is a proud member of the MedEd Media Network. Inspiration, information, and guidance on your journey to medical school and beyond at mededmedia.com.